All righty. I said we have about 40 minutes left here. So at this point, I'm happy to answer any questions you guys have for this upcoming exam on either the lab or the lecture material. So now is a perfect opportunity to ask those questions.
I was kind of wondering how it was broken down. So we're on the lab, we're obviously responsible for the histology of the bones, all of the bones and bone features and skeletal features. And then we're also responsible for the structures of the long bones and the flat bones. And am I missing anything else?
I could see doing the structures of the long bones on the lab exam. I'm not sure how well I mean, there really isn't much of an anatomy to the short and flat bones, but I mean, I guess I could, there's that pesky word diploe for the flat bones or something like that, but I can't see that being more than a question or two. Yeah, there's that. I mean, I know what we haven't gone over. We haven't gone over the knee. So let's do that. On your handouts, there is a knee anatomy list that you're responsible for. So I think everything else you said is accurate, but the knee is the one special joint you are going to be responsible for. Now notice there are some big differences, and let's actually, now that we've looked at this list, you see the things you're responsible for. Let's actually take the time to actually draw this in simplified form. One of the big differences between the elbow and the knee is, remember, the elbow, all three bones, the humerus, the radius, and the ulna, form the joint of the knee. I mean, the joint of the elbow. In the knee, it is just the femur, so there's clearly a femur and its components, and then here's our tibia. And we'll cheat a little bit. There's our tibial tuberosity. We'll shorten our femur, our tibia a little bit, and we'll do that for the medial malleolus. And there is the head of our, perfectly drawn example of a femur, but you get the idea. So obviously, the only bones that form the joint of the knee are the femur and the tibia. So we have the medial condyle of the femur, the medial condyle of the tibia, the lateral condyle of the femur, and the lateral condyle of the tibia. Because remember, the fibula only comes up and nestles up here underneath the lateral condyle of the, so there we go, underneath the lateral condyle of the tibia. So only the fibula, only the tibia and the femur form the joint of the knee. Now, this is a synovial joint, so of course we know both of these surfaces are going to have that articular cartilage on them. We know that is a feature. Whoops. But as we also talked about, there are going to be some special structures that can help as well. One of the first special structures are the ligaments that are going to help to stabilize this. And there are two external ligaments that we care about. The first comes from that medial epicondyle of the femur and attaches to the lateral condyle of the tibia. Seeing as this is on the medial side of it, and it is a ligament, and it is to the side. Not surprisingly, it is called the medial collateral, because collateral to the side ligament. This is also sometimes called the tibial collateral because it attaches to the tibia. Notice there is also going to be one on the lateral side that goes from the lateral epicondyle of the femur down onto the lateral condyle of the tibia, but also to the head of the fibula where it attaches there. So not surprisingly, this is called the lateral collateral ligament or the fibular collateral.
Are we allowed to use like either one, or is there specifically?
Both are appropriate anatomical terms. And remember, you're always allowed to use any appropriate anatomical term.
Okay, thank you.
Okay. However, there are also going to be two ligaments that are located here inside the joint. While many ligaments are located outside the joint, some ligaments are located inside the joint. So let's change our view to a lateral view. Here is that, as someone, I like the term they used before, like that knuckle of the femur coming down, and it is going to sit into the condyle of the tibia. And we'll, of course, put the tibial tuberosity there. So this is the front. There are two ligaments, and we'll make one light in color, and we'll make one dark in color. Both of them start anteriorly, both of them project posteriorly, and these two ligaments cross. So what do we call these crossing ligaments? Close. There is a meniscus in there, but remember that's that fat pad, that that fibrocartilage pad. There we go. They're the cruciate ligaments. And how do we distinguish them?
The one that's anterior is under, it kind of wraps under the
True, but notice both have an anterior component, both have a posterior component. So you've got the right idea. One is going to be anterior, one is going to be posterior, but we need a way to distinguish which is which. Luckily for us, if you remember, there is a raised bump in between the condyles of the tibia. And what is that raised bump called again? So the raised bump between the condyles.
the intercondyle, or I don't know, something.
Yeah. No, you got the easy part. Intercondylar eminence.
Okay,
absolutely, that intercondylar eminence. Absolutely. We identify which is which by their relationship to the intercondylar eminence. Notice this one, the pink one, attaches to the back of the intercondylar eminence, and this one attaches to the front of the intercondylar eminence. So the one that attaches to the front is the anterior cruciate. Oops. Ligament. And the one that connects to the back, in this case, the pink one, is the posterior. Excellent. These play a very important role in helping to stabilize the knee. Think about the knee as the knee were to move. If we were to flex the knee, bend the knee downwards, so we were to flex the knee, it was to come down this way. Notice as a result of that, this point would get closer to that point. So the anterior cruciate ligament wouldn't be doing anything, but our posterior cruciate ligament would be stretched out. So notice our posterior cruciate ligament is what stabilizes of the leg or the knee, let's say it that way, when the knee is flexed. Right? Think of it this way. If you're walking down the stairs and you bend your knee as you're walking down the stairs, all that force is coming forward on the knee. Do you want the head of your femur popping off the front of the tibia? No. So when it's flexed, that posterior cruciate ligament is what stabilizes it. Notice conversely, if we were to extend the knee, bring the knee back up to this position, then that is when we would be stretching out the anterior cruciate ligament. So the anterior cruciate ligament is responsible for stopping the knee from hyperextending, which, if you think about it, is how people damage their ACL. They're making that pivot or that turn and their knee hyperextends, or that linebacker comes and hits them and hyperextends their leg. And as it hyperextends their leg, it tears their anterior cruciate ligament. So these two crossing ligaments help to stabilize the knee. And notice we've got this here, but we also, not only in our handouts do we have this knee joint handout, but if we go back to the modules, notice there is actually an image of a knee model. Notice as we look at this knee model picture that we can see here, we can clearly identify these ligaments that we've been talking about. There is that lateral collateral ligament. We can see the teeniest bit of the other one on the side. We'll look at some other images, but notice we also have those crossing ligaments here in the middle as well. Let's look at another picture. Here we go. Notice here from the posterior view, we can clearly see the medial collateral ligament. And how do I know this is the medial collateral ligament? How do I know this is the medial collateral ligament? Exactly, because the fibula is lateral. This one's connecting to the tibia, so that must be medial. Whereas then that means that this one over here is the lateral collateral ligament. Notice here we see the crossing ligaments. We see this one starting from the back and moving forward, whereas we see the other one that must have started in the front and came to the back. So notice I can see them both from the back, but this one that I've painted brown, which one is that one?
Posterior.
Yeah, because it starts behind the intercondylar eminence, whereas this one doesn't. Notice we have another picture. Oops. We can see it nicely from the front. And again, notice here we can see those crossing ligaments. The one that starts in the front and goes back is the anterior cruciate ligament. The one that starts in the back and comes forward is the posterior cruciate ligament. Notice this picture shows one other really nice thing. This here. Notice in blue, we have our hyaline cartilage, our articular cartilage that is located on the ends of the bone. But notice there are these additional chunks of material here in the middle. Any idea what those might be?
Is it like the never mind. I was thinking of like the, I can't say, it's like the bursa or something like the sacs.
Not a bad guess. It is an accessory structure. It is a big chunk. What if I told you that this happened to be fibrocartilage? Big chunks of C and circle-shaped fibrocartilage that is providing extra cushion in the joint. Oh, if only I had a list of the anatomy of the knee I was responsible for. I might be able to figure out what these two rings of fibrocartilage is. There you go. Mitch has got it. They're the meniscus, or plural, the menisci. Excellent. And this one here that I'm circling in green, which one do you think that one is?
Collateral.
Lateral meniscus. How do you know it's the lateral meniscus?
Because the fibula is on the
Yeah.
lateral.
Fibula is lateral. Excellent. So that tells us that that is lateral. And so the one that is still brown, that would be the medial meniscus. All right. Notice we can see the menisci there as well. Here we can see the menisci. So we have a couple images here that do a nice job of showing these. We have some good models in the classroom that show this. And you'll notice there's one more thing on your list. And I think I like this version of it better. I don't like any of these actually. All right. You have a big, large muscle group up here on the thigh known as the quadricep muscles. These quadricep muscles, all of their tendons come together to form a structure that is known as the quadricep tendon or the patellar tendon, because they're going muscle to bone. And that bone happens to be the patella. However, notice there is a continuation of that dense irregular connective tissue that goes from the patella to the tibial tuberosity. And this is known as the patellar ligament, because ligaments go bone to bone, tendons go muscle to bone. So this patellar tendon and patellar ligament also help to stabilize the knee. So notice there are 5 ligaments you are responsible for. And again, if we go to this picture, it shows both of these kind of show all of them. 5 ligaments you're responsible for on this exam. Here, let's cheat and do the next one. Patellar ligament connects patella to the tibial tuberosity. Lateral collateral ligament. We can see a little bit of the medial collateral ligament there. And then the 2 cruciate ligaments, anterior cruciate and posterior cruciate. So 5 ligaments we're responsible for. We're responsible for the menisci, and we're responsible for the articular cartilage. And I think that's it. Am I correct? Is there anything else on that list? Perfect. So there you go. So we got on this because you were talking about the things that are going to be on the exam. Obviously, the bulk of this exam is going to be bones and bone features and skeletal features and skull features. That's going to be the majority of it. But you're right. There is some histology. And remember, we can do histology from the microscope, and I guarantee there's going to be some microscope on it. But remember also, we've got that great bone histology model. I thought was on here. I think it's bone model pictures. Yeah, remember this model is also histology, showing the different lamellae, showing the endosteum and the periosteum, showing the Sharpie fibers, and we can see the lacunas and the canaliculi and the concentric and circumferential and interstitial lamellae and all the things that we talked about as well. Perforating canals and central canals, everything that's on the histology, we can see on this as well. So that would be on there. And then, so some histology, and then some joint stuff. And I think then that's it. I say that's it, but that's a good list. Yeah, I think those are the things that are going to be on this exam. And the knee. All right, next question.
Are you mostly going to be using the images you're providing, or will there be any other type?
I will not purposely avoid using the pictures that I'm providing, but my goal in this class is not for you to memorize the pictures I've presented for you or memorize the pictures in the textbook. The goal is for you to understand this information. So just like on previous exams, as long as I believe it to be an obvious example of something, I have no problem showing you something that I may not have shown in class, just as long as it's an obvious example. Again, my goal isn't to be tricky. This class is hard, and so I don't have to be tricky, and that's what I love about this class. But the goal of this class is to understand the material, not to memorize one picture that I've shown you. So you need to be able to recognize the features of an ethmoid bone from any picture of an ethmoid bone that I show you. But yeah, am I going to use pictures that I've used? Those, I already told you, those bone models are definitely going to be on there. The chart pictures are definitely going to be on there. If you think that sagittal's picture of the brain, I mean of the head, has a lot of bones that we looked at and bone features, sinuses, we saw the dens, we saw the hyoid there. So yeah, absolutely. Any good example I will use. But yeah, they're definitely some of the things that I've used because they're from the classroom are going to be what's on the exam.
It's mostly like the bone features that can look very different to me on different pictures, like
Yeah.
especially foramens, like one that's like, you know, color coded and like a drawn versus a real, they can seem very different to me. So it really throws me
Well,
off.
I will tell you right now that I am not going to be using color-coded images. I'm not going to be using illustrations. I will be using pictures of real bones. I know most of the groups used illustrations because they're nicer, and drawings are often color-coded. They're often stylized to look more obvious, but
Mhm.
you are
Yeah,
responsible
'cause
for bones.
I
If
try
you're
not to
in the-
use those for that reason,
Well,
because
so I will also remind you, if you're not doing so already, remember also that a great resource for studying this, obviously go
The PAL.
into the open lab if you can do that. Yeah, absolutely. The PAL CD is a great resource. So again, if you're not using that PAL CD, first and foremost, shame on you.
yeah, I did a lot of that
But-
yesterday, and you can
Yeah.
even select the specific features you want to be quizzed on.
Yeah.
So it leaves out all the ones you don't really need to know. And that's why it kind of showed me like, whoa, this looks very different than what I thought. Like some of them I thought was the ovale, when really it was like the jugular, you know, so it's just like using those was like, oh, it looks so different to me.
Right. And again, everybody's
I don't
skull
know.
looks different. So absolutely. So yes, that PAL is a great program, a great way to study this. And then once you start feeling comfortable, then go to the almighty Google, you know, search for skulls, search for femur, and then see if you can identify those on those random pictures. So yes, start with something like the PAL, start with your, you know, you've got a photographic atlas.
Mhm.
Where's my photographic atlas? I don't know where mine is. But you have a photographic atlas, which does a great job. I have an old one. Yours is actually much nicer than this, but this also does a really good job of giving you the starting points, showing the bones, showing you the bone feature. So start with the really obvious things. And then as you start getting more comfortable, then yeah, go to the almighty Google and quiz yourself on stuff like that. All right. Aubrey, did you have a question?
Yeah, I did. It was actually about the nasal septum. I was curious if this was the same thing as asking what bones made up the nasal cavity.
No. Remember, the nasal septum is the skull feature that divides the nasal cavity in half.
Oh yeah, that's right. Thank you.
Whereas, and again, I've actually gotten this question a couple times. So like, for instance, again, here is your nasal cavity. It has a roof, it has a floor, it has sides. Now, it is absolutely 100% true that you have a nasal septum that divides that nasal cavity into two separate compartments. All right. The reason we do this is actually really interesting, as we'll talk about when you get to 431. Part of the job of our respiratory system is not just to get air in our lungs, but to process it, to warm the air, to clean the air, to moisten the air. So at any one time, one side of your nasal cavity may not be optimal for doing that. So we actually have erectile tissue inside of our nasal cavities, similar to the erectile tissue in the penis and the clitoris. And so if one side isn't optimal, that erectile tissue will enlarge and that area, that side becomes a little congested in there. So if you, at any one time, if you try to breathe in from both nostrils, you may see that the air moves more freely through one side than versus the other. So during the course of the day, one side will swell and the other side will swell, and a different air will move in different points to maximize that efficiency. So if we're talking just about the nasal septum, this is the nasal septum. if I'm asking you to define the boundaries of the nasal cavity, well, then that's the roof and that's the floor and that's the walls. Now, this could be considered a wall in the nasal cavity, but it really doesn't define it. So on the review, if you include that, I'm not going to mark it wrong. But if you leave it out, I'm not going to mark it wrong either. Because whether or not you want to consider that dividing structure as part of defining the shape of the nasal cavity, I could go either way on it. So again, you can make sure you get the roof, the sides, the floor. Whether you put the nasal septum in that or not, it's accurate either way. I don't care. Both are considered fine. But they're not the same thing. Does that make sense?
Yeah, thank you.
Yep. Excellent. All right. What else you guys got? Amanda.
Yeah, so you mentioned or in the presentation that the widest part of the hips would not be the iliac crest. So then would it then be the posterior superior iliac spine that's the widest part of like the actual hip?
I will remind you that that is part of your 30-point review where getting the questions are you graded on correctness. So I will not give you the answer. However, I mentioned that the iliac crest is not part of the hip joint. So what did you just ask me about?
The widest point of the hips, not the
No,
hip
but
joint.
so what did you ask me if was? So what was the bone feature that you suggested?
The iliac crest.
Okay, that was what you said first, and we already know that's not the right answer. But I thought
Right,
you
the posterior superior iliac spine.
is that a part of the joint that is the hip?
Yes.
Really?
Is it? Is it?
I don't know. You tell me. Here. Let's do this. Show me the hip. Up at the top, you should have an option to annotate. Do you see that in your options up at the top?
Oh no, I had to move to my phone because I.
Oh, okay.
Oh, I see. I see a little. I see it. Okay.
Okay.
Okay. Let me zoom in. Oops, I didn't mean to do that one.
That's all right. Put a circle around the hip.
Okay. Did it do it? Sorry, it's hard to do
All
this
right.
on my phone.
I appreciate that. It's close. It's a little sloppy, but it's pretty close. So what's the question on your 30-point review?
The widest point of the hip.
Okay. So what I would do is I would look inside that circle that you've drawn, and I would find the part that sticks out most laterally. That's what I would do if I was trying to answer this question. All right.
Okay.
Any other questions?
I do have one.
Yeah.
So looking at the inferior orbital fissure,
Mhm.
it is made out of 3 bones, correct?
Let's call it 2.5.
Okay. Is the half the maxilla?
Yeah, exactly. For it is one of those things where it varies dramatically from people. For some individuals, it does go lateral enough where it will include here. So this is a great picture. So for some individuals like this one here, Notice it goes lateral enough where it actually does get all the way to the zygomatic bone, but it's not going to be that way for everybody. So it absolutely positively is the maxilla, absolutely positively is the sphenoid. And again, the zygomatic is one of those where if you put it, I wouldn't mark it wrong. If you left it off, I wouldn't mark it wrong, because there is a little bit of variation from person to person. All right.
Thank you.
But if you put parietal, is that right?
No.
No. So yeah, we have a little bit of flexibility on this, some morphological differences from person to person, but there's clearly some bones that it's not. But yeah, the half bone is the zygomatic. So again, that's another perfect example where for some people it will, for some people it won't, and it's going to vary from person to person. So I would accept both of those answers in that case.
Then I did have two more if no one else.
No one
Okay,
else seems to be speaking up, so by all means.
awesome. So I was trying to find it in the book and I didn't want to Google anything, but I had a hard time finding the stylomastoid foramen and the carotid canal.
Okay, excellent. Let's start with the easy one first, although they're both pretty easy. This big round bump behind the head, behind the ear, I should say, is that mastoid process. Right here, I think it's even a little bit better. You can see that big bump. It's a big muscle attachment point. It's that big bump you can feel behind your ear. This long, narrow, prominent feature isn't something that can be felt. And in fairness, on this side, it's actually broken off. So we can see where it would be located, but it's broken off on this point. But it is this long pointy thing that if we, here, let's cheat for a second and go back to, here we go. Even better. Big, round, mastoid process, long, narrow, styloid process. We comfortable with those two?
Yeah.
Okay, so when we look at this from an inferior view, well, this one's kind of nice. Although notice the styloid process is broken on both of these. That's where the styloid process would be. Here's the big mastoid process. Here's the big mastoid process, and here's where the styloid process would be broken off. And notice right in between them is this tiny little hole. That tiny little hole right there is the stylomastoid foramen. Yeah, it's hard to find because it's small. Notice this probe would barely fit in it. Probably wouldn't go very far. It's a tiny little hole. Remember, this is the one where I mentioned the facial nerve comes out to move your face. So if you get swelling in your mastoid sinus, it can constrict that and cause that paralysis, that Bell's palsy that we talked about. Right? And it only goes into that middle ear space, that magic space in there. It doesn't come out on the inside. So you're only going to see it from the underside of the skull. That's the other trick of this one. It's only on the other side. It doesn't go all the way through. So even if I had a probe that was small enough, I wouldn't be able to shove it through and have it come out in the inside of the skull. Okay. So the second one is the carotid canal. And the key word to that is indeed canal. Notice, and again, a lot of it is about orientation. Our probe here, any idea what bone feature our probe is actually going through? The same one over here as well.
That's the jugular, right?
Yeah, that is indeed the jugular foramen. Exactly. And right next to the jugular foramen on the underside of the skull is our opening for the carotid canal. So on the underside, the inferior view of the skull, it is right next to the jugular foramen. But its name tells you everything. It's a canal. Notice as my probe is showing, the jugular foramen points back to the back part of the skull. Our carotid canal actually tunnels through this bone of the temporal bone and comes out in the front. So it is actually tunneling through this bone right towards the foramen lacerum. So notice up here is that irregular opening, the foramen lacerum. So notice we have these three openings that we care about right now. I'll make this nice and big and color them in. We are looking at the foramen lacerum, a skull feature. We are looking at the, the jugular foramen, a skull feature. And we are looking at the carotid, we are looking at the carotid canal, which is a bone feature. And notice on the underside of the skull, on the inferior side of the skull, the carotid canal is right next to the jugular foramen. All right, we comfortable with that? But notice it tunnels through the bone towards the foramen lacerum. So notice if we switch our view and look at the skull from the inside, notice now, as we saw before, the jugular foramen is pointing out here posteriorly, coming out there. Our foramen lacerum is this roughened opening right here. And what's actually happened with our carotid canal is notice we don't really see an opening to the carotid canal. That is because it is tunneling through that bone and is actually coming out right here where the foramen lacerum is. Now, the good news for us is that students like to look at like to look at skulls. And when they look at skulls, they tend to be a little rough on it. So let's see if I can find a different picture. Nope, I don't have a different picture there. So let me try this instead. That one's better, but I still don't like it. So that's the problem with getting pictures of nice bones. Yep, nope, I don't have a good picture of it. So let me see, let's cheat and go to the almighty Google. Now it's a fake one. It's a fake one. These all suck. All right, I'm not finding an easy, quick view, and now we're losing. Oh, wait, hold on. All right. This one's not great, but it'll do. Clearly, I wouldn't use this on the exam, but oh, no, I didn't mean to open up my mail. Go away. There you guys are. Couldn't find you. All right. This is not the best view, but the ones in the classroom, if you get a chance to look in the classroom, what people often will do is they stick a probe into that carotid canal. And because it tunnels through this bone, they often break the superior part off. So you can actually see the opening. And that's what you're seeing a little bit here. That little bit of darkness that you're seeing there is where there's damage of that tunnel coming through. So that carotid canal tunnels forward and it basically comes out where the foramen lacerum is. So it starts back here, right next to the jugular foramen on the outside, but on the inside, it basically comes out where the foramen lacerum is. So again, from an anterior view, from a superior view looking down, it can be hard to see the carotid canal. So both the carotid canal and the stylomastoid foramen are something that's much easier to see from an inferior view of the skull. So when we're looking at this from an inferior view, it's going to be much more obvious. All right.
Thank you.
Excellent. Did you have another one or was that it? So vertebral prominence, again, something that's on your 30-point review, so I can't give you the answer to it, but what can you tell me about the vertebral prominence? What do you know about it?
Is that like the spinous process of the vertebrae?
All of them?
The cervical vertebrae specifically?
All of them?
I want to say no, since you're asking.
I would think that that's reasonable as well. And in fact, Sarah's also pointed out only one. So now your goal is to figure out which one.
Okay.
Again,
So is the 30-point review like a good study guide for our exam?
it is a good study guide, period. Because again, remember, as we talked about on the exam, I could show you a picture of a bone like this. I could have an arrow pointing like this, and I could ask you, identify this bone and bone feature. And what would your answer to that be?
Femur and femoral head.
Excellent. Femur and femoral head. I could ask you to identify whether it is right or left. And is this right or left?
That is the right.
It is indeed the right. But I could also ask you, and in this case, I would ask you, identify the skeletal feature that articulates with this bone feature. And what would your answer to that be?
The oh gosh, I don't know. Well, I don't know. I learned it today, so.
Acetabulum. And again, I don't
Acetabulum,
care
yeah.
how you pronounce it as long as you spell it correctly. Right? Exactly. So again, the whole second and third page of that review is understanding the relationships of the bones. So again, here's another great example. I could take this and I could grab my arrow and put it here. And I could ask you to identify that bone and bone feature. And what would your answer be?
The iliac tuberosity.
No, you get partial credit for that.
Oh, so the ilium is the bone in the articular surface.
Close. Is it articular
Auricular.
surface?
Auricular.
Auricular surface. Excellent.
That's what I meant
It
to
is-
say,
There
sorry.
you go. No problem. It is the auricular surface of the ilium. Excellent. But again, could I ask you to identify the bone and bone feature that articulates with it?
Yes.
And what would the answer to that be?
The
Auricular surface of something else.
It is the auricular surface of the
femur, head, femoral head.
sacrum.
Sacrum.
Sacrum, there you go.
Oh, sacrum.
Yeah, the auricular surface of the sacrum. Excellent. And identify is this skeletal feature, because this is indeed a skeletal feature. Identify the skeletal feature. Well, here, hold on. Let's get rid of the arrow. Identify the skeletal feature. What is this skeletal feature?
Os coxa.
Yeah, os coxa. Excellent. Is it right or left?
That is the
Right?
It is indeed a right. There you go.
How do you
So
tell?
I don't know.
Okay.
No. Pubic bone is anterior.
Okay.
Remember, our group pointed out that this is the greater sciatic notch. What do you think passes through the greater sciatic notch?
Sciatic nerves.
Yeah. And if you have sciatica, where your sciatic nerve is irritated, where do you feel that pain?
Lower back.
Yeah, in your back. So the greater sciatic notch is posterior. So that's posterior, that's anterior. And of course, the acetabulum has to be where the femur connects. I can't see the acetabulum, so it must be on the other side of this. So if the acetabulum is on the other side of this, then this person is basically looking at me, standing there looking at me. And if they're standing there looking at me, would this be their right hip bone or their left hip bone?
They're right.
They're right. Exactly.
Thank you.
All right. So yeah, that study guide is, again, it's worth 30 points. So obviously it's important. And understanding not just bones and bone features, but how these things relate to each other as well.
On the first page of the study guide, I think it's like the second part, you ask us kind of informal, like for example, like the bump on your ankle, like, is that how you're going to ask certain questions on the exam? So we have to understand like the common terms, I guess.
So let's think of it this way.
That's why I'm having trouble with the hip.
Okay. In the past, for instance, when you did that Physio X exercise, like the membrane transport, of osmosis and diffusion, did that turn out to be an essay question on the exam?
Yes.
Yeah. So if I have a 30-point review, are some of those questions likely to show up on the lecture exam?
Yeah.
Yeah, absolutely. Right. That would, what forms the medial bump of your ankle isn't going to be on the lab exam.
Right.
But are those the kind of thing that could be on the lecture exam? Yeah, absolutely. Being the smart, sophisticated student, you should be expecting stuff like that. Absolutely. Anything worth 30 points has got to be important. All right. What else you guys got? Oh, we're way past time. All right, I'll tell you what. I've got office hours after this. If you have more questions, come to my office hours, email me. I will be around this weekend, so if you have questions, you can email me that way. I have office hours tomorrow from 11 to 12, so I can meet you there if you want to. Right after class, we have that as well. So I want to go ahead and end this now because, again, I know people have other responsibilities, so I don't want to go late and go past that. So we will stop the lecture there. But if you have any other questions, pop over to my office right after this, and I will happily answer them.